Hi everyone, it's Dr. K, and we are going to be talking about your activities in week 7. So give me just a moment and I'm going to share my screen with you. All right, so you can see we are here in week 7. So for this week, you have 2 chapters of reading, which is your Bates Guide, chapter 10, and that is skin, hair, and nails, and then chapter 23, and that is your musculoskeletal system. So we're going to talk about MSK in a lot of detail, and I will get to those slides in just a moment. Also important reminders for this week, you do have your QBank modules due, and so you need to earn at least an 84% on that, complete a minimum of 40 questions. Unless that bank does not have 40 questions, then you will just go ahead and do the amount of questions to maximize there. You can do it in tutor mode or exam mode, and then you're going to submit that screenshot by the due date, which is by next Monday. And those grades are always average. So for this week, you do have ortho and derm. And then your MSK video and write-up we'll talk about in great detail in just a few minutes. Make sure that this is your 3P APEA exam week that you have scheduled, that you have time planned out to go ahead and take that exam with Proctor U, and follow those directions from the email from Dr. O sent you. If you do not score a 70% or greater, you will be required to complete the remediation, and there is a separate email that was sent on how to do that. And then additionally, please make sure that your week 8 group project that you are working on that and that case scenario that was given to you by your instructor. So first, we're going to talk a little bit about skin, and it's going to be very brief with some direction and where to look in your book for this. So when it comes to skin lesions, you need to know those A, B, C, D, E's. And there's actually a little elaboration on that as well. So you can see this A, B, C, D, E, E, F, G, and that's what's listed in your book on figure 10.4 and box 10.4, and those page numbers are listed for you. And so the A, B, C, D, E's are your asymmetry. You're going to be looking at the border irregularity, the color, diameter to make sure that if it's greater than 5 or 6 millimeters, elevation, especially if there's irregular borders with that elevation or if it's growing, that firmness, and then growth. So in terms of skin, there are lots of different lesions we might see. And so your book does a very good job of talking about these, what they actually look like, and pictures of those, as well as describing those. So we've got several here for you to look at, and that's macule, patches, papules, vesicles, nodules, pustules, bulla, furnicles, wheals, subcutaneous mass. And then some other really great resources in your Bates book to take a peek at are the pressure injury staging, as well as the risk factors for melanoma, and then very good pictures for keratosis, squamous cell, and basal cell carcinomas. When it comes to findings on or near the nail, there are several different conditions that you may see. And so a few listed here are paronychia, clubbing, habit tick deformity, melanychias, oncolysis, onychomycosis, terry nails, and pitting. And then there is a great table for you, table 1010, and that's on page 326. That's going to talk about many different systemic illnesses and diseases that are linked to skin manifestations and conditions that you might see. So I highly recommend taking a peek at that, as that will help you tremendously when it comes to clinicals. Now we're on to MSK, and we're going to talk briefly before we get into our weekly rubric. And so specifically, I want to mention the 3 different joint types, and those are synovial, cartilage, and fibrous. And so the extent of movement with those joints varies, as well as examples of those joints are listed there for you, and that's based on your Bates book. And then you can see on the bottom, the knowledge of these joints is going to help you be great in terms of clinical diagnosis. Assessing joint pain, you definitely want to make sure you're asking your patient very good questions. And so this is a lot of times where that old carts is going to come into play, but you want to ask your patient to pinpoint the location of their pain. So specifically, point, and one finger if possible. Show me where you hurt. Can you point and show me? Again, with characterizing that pain, you want to ask them about location, quality, quantity or severity, the timing, onset, remitting or exacerbating factors, and associated manifestations. So you can ask these questions of, tell me, when did this pain start? You want to know if it's acute or if it's chronic. What is the exact mechanism of injury if they can remember one? Does it seem articular or extra articular outside of the joint? Is it inflammatory based or is it non-inflammatory based? And then localized, meaning it's one joint or monoarticular or diffuse polyarticular. And then asking the patient to describe that pain to you. And I've given some examples there. In assessing neck pain specifically, this is very common that you're going to see this in varying degrees in acute and chronic. What we need to be sure of is if it's a traumatic mechanism like a car accident or even a bicycle accident where they're over the handlebars or fall on their side, you want to rule out the risk for cervical spine injury and assess tenderness to palpation and range of motion. Those are the tools that are going to help you decide if imaging is actually needed for that patient. So again, characterizing the pain, acute or chronic, location, quality, severity, timing, what makes it worse, what makes it better, and does it radiate? So radicular pain definitely signals nerve compression, and you can see additional information there. When it comes to assessing low back pain, we often see this in those age groups of 35 to 55, and a lot of times that's due to work-related injury. So characterizing the pain, these are same questions that you're asking those old carts that we just covered. Most of these guidelines do group low back pain into non-specific, nerve root entrapment, spinal stenosis, or pain from an underlying disease or condition. So two things to consider is the pain midline? Is it when you press down the spine or vertebrae itself, or is it paraspinal, meaning it's not overlying the spine? And some differentials to consider have been listed below for you. You also need to be very concerned if your patient has any of these red flags for cauda equina syndrome specifically. And so the symptoms of those back pain red flags are saddle anesthesias, meaning they have loss or numbness change in sensation to their genital region. So testicles, scrotum, anus, vagina. You want to be very specific about that with your patient. A lot of times when we talk about bladder or bowel incontinence, we forget to also remember retention. So somebody who's not able to void completely is also very worrisome. And that's when we're seeing on those bladder scans, the bladder does still hold urine in it after the patient has voided. Neurologic symptoms and lower extremity weakness. So we're talking about foot drop, numbness, motor weakness. They're not able to walk from their baseline. And then those high-risk conditions for cauda equina or serious back emergencies are also listed for you. When it comes to your back exam, you want to be very systematic. You want to visually inspect and look, palpate and feel, and then evaluate the joint movement. And so that's for anything with musculoskeletal specifically. There's special maneuvers that you're going to need to do to try and stress a joint if it's possible to elicit pain response or get a better idea of what the origin is of the pain. So now we're on to our rubric for this week. And so this is based on your MSK video that you're going to complete, and then we'll talk about the write-up at the end. So in terms of your rubric, I have ordered these in a head-to-toe manner. You are more than welcome to memorize the rubric, but when I think about assessing a patient, I start with the head. And so I'm specifically thinking, how am I going to work my way down so that I don't forget anything? Again, the rubric is slightly different in terms of the order, but you can go in whatever order as long as you're completing these. So with head and neck, again, we're going to inspect, palpate, and range of motion on any MSK thing that we're doing. So specifically, we're looking for deformities, abnormal posture. You're palpating the TMJ bilaterally. Remember, those light purple are going to tell you exactly where to look in your book on specific pages and great tables. So I do have those listed for you. Palpating the the sternoclavicular, cervical spine, paracervical muscles, trapezius muscles, and rhomboids. And so while you're palpating, you want to mention specifically what you are palpating on your patient. You want to state those names of those anatomic locations. With range of motion, flexion, so touching the chin to the chest, extension, putting the head back is hyperextension, rotation, rotating the neck side to side. Lateral movement, touching the ear from side to side, open and closing the mouth at a degree. And so basically what you should be able to see is that the patient is able to hold 3 fingers vertically and open their mouth, and that their jaw does not kind of clamp close or that they are having difficulty opening. Lateral movement with the mouth open and moving the jaw side to side. Specialty tests, and you can see a picture here of the Sperling test pulled from your Bates book. I do highly recommend a really great resource on YouTube called Physio Tutors, and they have great demonstrations if you want to put in these specific tests to see them performed as well. So with your shoulders, you want to inspect bilaterally, posteriorly, and anteriorly. You're going to be looking for swelling, deformities, redness, atrophy, nodules, and joint symmetry. When you're palpating, you're noting for tenderness and fluid. Again, there's a Bates page for you to take a peek at, and you're looking at the AC joint, the biceps groove, the tubercle of the humerus, the coracoid process, the subdeltoid bursa. You want to make sure that you're verbalizing those appropriately while palpating over those locations. With range of motion of the shoulder, that you're flexing the shoulder forward, extending it backwards, abduction and adduction. So the easiest way to remember abduction and adduction is ADD is adding. You're always bringing that back together, where abduction is pulling it away. Internal rotation and external rotation, you're placing the hands behind the neck with the pillows outside to show that. And then there are specialty tests, many of those that are used for the shoulder. You're going to pick one for your video and you're going to demonstrate that. And so that can be your painful arc test, which is going to be looking at shoulder impingement, the near test, the Hawken, the drop arm, the empty can. So specifically, you want to make sure you're performing it correctly, identifying the structure and what defect it's testing for, such as with the empty can test, testing for supraspinatus strength. And if that is abnormal, a possible rotator cuff tear can be suspected. So here's some shoulder range of motion to show you specifically what these look like. Again, these are pulled directly from your Bates book, which is the phenomenal resource that you have available to you. So please check that out. Make sure you are reading and looking over these as you're practicing for your video. You can see rotator cuff testing, as we just mentioned. That's with the painful arc test and the near impingement test, and showing you what would be an abnormal finding there. When we're looking at the elbows, we're inspecting, again, always inspecting first, redness, swelling, nodules, and joint symmetry. You're looking bilaterally. You need to make sure when you're performing everything musculoskeletal that you are performing that bilaterally, if that's an option. With palpation, you're going to note swelling, nodules, or pain. The extensor surface of the ulna, the olecranon process, you're going to press on the lateral and medial epicondyles looking for pain and indicate which area would show golfer's elbow or baseball elbow versus tennis elbow. With range of motion of the elbow, you're going to show extension and flexion, supination and pronation. And so I've shown these pictures here for you, again, pulled directly from your Bates book and what figures, as well as the pages you can find those on. With your hands, inspecting for swelling, deformity, redness, muscular atrophy, nodules, and joint symmetry. You've got this great picture here of the anatomy of the hand. With palpation, that you're palpating over the distal and proximal interphalangeal joints and the metacarpal phalangeal joints. Range of motion, the ability to make a fist and testing that function. Flexing and extending the hands, abducting and adducting the fingers together. Again, some great visuals. With the wrist, you're going to be evaluating for swelling. So synovial membrane is going to feel boggy or doughy. You're going to be looking for deformity, redness, atrophy, nodules, joint symmetry. Palpating over the wrist, you're going to make sure that you're palpating the metacarpals and the carpal bones, which we showed in that anatomy picture just on the previous slide. Range of motion, flexion of the wrist to 90 degrees downward and extending the wrist 90 degrees upward. You want to be very precise in mentioning and verbalizing those range of motions and the degrees. Ulnar and radial deviation of the wrist, and that's abduction and adduction again. Your specialty test with the wrist, there are two that are often used. And so that is the Tinel and the Phelan sign. And again, there's photos here pulled directly from Bates, so you have an idea. Those positive signs with the Tinel sign is pain or that should not say parentheses, it should say paresthesia, radiating down the palm into the index, middle, and lateral half of the ring finger. Whereas the Phelan test is going to be kind of that phalanx. You're making those hands kind of bow together, and you're going to verbalize that at 90 degrees. You would have the patient maintain that for 40 to 60 seconds to elicit pain or a response for a positive test. However, you can verbalize that you are doing that for that time period, and you don't have to waste time on your video. When it comes down to our hips, we're now on our lower extremities. So basically, I've worked my way from a head, neck, shoulders, elbows, wrist, hands, fingers. Now, if you're holding your hands by your side, you're going to be about your hips. So we're going to start there. Inspecting the hips for swelling, nodules, redness, and alignment. With palpation, we're taking a look and feeling over the anterior superior iliac spine, our greater trochanter, our posterior superior iliac spine, and the sacroiliac joints. With range of motion, we are asking the patient to do that actively as well as helping them through this range of motion passively. So you're showing both. Flexion of the knee, and that's at 45 degrees externally and internally to rotate the leg. Active and passive hip flexion, active and passive extension of the hip. Abduction, adduction, again, those are going to be at varying degrees. And then with the hips, you have specialty tests. And again, Physio Tutors does a great job of showing you the Thomas test as well as the Patrick's or the Faber's test. And there is a visualization of that Faber test there for you. When it comes to the knees, we're inspecting for swelling, nodules, redness, alignment. We're looking for varus or valgus deformity. That is something that your board exams usually love to ask you about. So I do highlight making sure you know the difference between valgus and varus deformities. Palpating over the suprapatellar pouch, the sides of the patella, the popliteal fossa for Baker's cyst, and then range of motion, extending that knee all the way outward and flexing it to at least 120 degrees. Several tests are required to be shown with the knee. We do often see knee complaints, and we need to know, again, are they acute? Are they chronic? Are they inflammatory? Are they trauma-based? So these tests do help us, especially when knowing what structures are affected with the knee. So the valgus stress test, as you can see, is going to be testing the MCL, and the varus stress test is going to basically adduct that lower leg, whereas the valgus is going to abduct. Your Lockman test is assessing the laxity of the anterior and posterior cruciate ligaments, or those ACL and PCLs. Again, it gives you instructions on how to perform that. Your anterior drawer test is testing those cruciate ligaments. So when done properly, the Lockman test is more sensitive though. And then the McMurray test is medially rotating that tibia and extending it, and that's going to help to decide if there's a meniscus injury. All of these tests are commonly performed in primary care settings, internal medicine, urgent cares, even ERs. So you need to know how to perform these tests properly to evaluate the patient, because imaging is not always available. And if you're going to order an x-ray of a knee, you need to know specifically, are you ordering a 2-view x-ray? Are you ordering a 3 or a 4-view? What is the difference? What are you looking for with each of those? And so we want to make sure that you know how to properly examine the patient and assess their needs specific to their musculoskeletal complaint. Now we're on ankles. Again, we're inspecting for swelling, deformity, nodules, and discoloration. While we're palpating over this anatomical structures. So medially are on the inside and laterally at the malleolus, and you're testing over the Achilles as well, palpating on the gastrocnemius for nodules and tenderness. With range of motion, you can see 2 photos here, and you have dorsiflexion and plantar flexion. So a good way to remember plantar flexion, or plants grow on the ground, you are always planting downward, and then rotating the ankle in circles. And so you're showing that, again, active and passive. With the feet and toes, you're inspecting for calluses, deformities, corns, nodules, plantar warts, bunions. For flat feet, we call that ples planus, and you're going to verbalize or observe that, and that's best seen while the patient is standing. Your Bates book does have a great photo of that as well. Palpating for any interdigital neuromas or a Morton's neuroma and plantar fasciitis. And then over those distal and proximal interphalangeals and those big metatarsal bones of the foot. You're going to show that range of motion, so flexing or curling the toes and extending them outward, and then inverting and everting the foot. When it comes to the spine, this is one of the last portions. So I would have the patient turn so we can see on the camera. You can adjust your camera as such. You're going to be inspecting while the patient is standing at the cervical and the lumbar lordosis, as well as the dorsal kyphosis from the side. So you're going to be standing in front of the patient, looking at at the back of the patient, looking at the patient's back, and then have them on their side, or you're going to turn to your side as well. Shoulder height, you're looking for symmetry at the height of the shoulders, as well as that iliac crest, that they look symmetrical. The skin creases below the buttocks, and you're going to verbalize that, but not demonstrate. Dorsolateral spine is going to be when they're bending forward, and so you're going to have them bend forward as far as they're possibly able to. You're looking for symmetry of movement as the patient flexes and extends. Is one shoulder higher than the other? Is one hip higher than the other? With smooth curvature of the spine? Do we see any lateral deviation or possible scoliosis? We're looking at that range of motion. So how far can the patient bend? And 90 degrees is normal. With palpation, we're palpating over the spinous process and the intervertebral spaces. You're going to also percuss over the spine. So remember how we do percussion using the ulnar surface of your fist. And then with range of motion of the spine, we'll look at that in just a moment in an additional slide. But you're going to basically be stabilizing the patient by standing at their side, and their back should be to you. You're going to have them bend to the right and to the left to show lateral bending at 35 degrees, bending back towards the examiner. So that's an extension of 35 degrees, and then twisting the shoulders right and left. And that's a rotation of 30 degrees. And then your special test is the straight leg raise. That is best performed when the patient is lying down in a supine position and you're raising that leg forward. So again, here's spinal range of motion to show you exactly how it's visualized in your Bates book with flexion, extension, rotation, and lateral bending. And then we are at the end of our MSK. So professionalism, you're getting your points for wearing your lab coat, appearing to be in a professional dress and attire. You're not wearing scrubs, you're not barefoot. You verbalize that you washed your hands with autonomy. You want to make sure that you're performing this without notes, that you're doing this from memory. You are also very close to getting to your head to toe exam. And remember, you can submit that at any time. So be very specific that you are making sure in memorizing exactly what needs to go into this exam, which will be different from your head to toe. I do recommend definitely writing these things on note cards while you're practicing to help you get an idea of what goes in what area. You always need to make sure before you start recording that you have obtained consent from your patient. So you've obtained consent and that they are verbalizing their understanding, that you are going to record this video, upload it to YouTube for your instructor to grade. That's the only reason that you're recording it. You can also use any patient at this time, age 6 or older. If you are their parent, you do need to give their consent. You can make sure that they are clothed. If they do not feel comfortable wearing a shirt where we can see the spine, you would again just verbalize those things to us. You want to be constant in your communication, making sure that you are verbalizing each step as you go and that your flow and position is organized throughout the exam. Your exam itself is worth 75 points, and then you do have 25 dedicated points to your documentation. So when it comes to your write-up, this is different than your SOAP note. Remember that a write-up is going to be focused on the physical examination findings or the objective only. And so the way to do this is to basically go back through that rubric that we just covered. You make sure that you're writing out in detail exactly what you did, where your hands were, what degree of range of motion to be able to perform that test if it was positive or negative for any specialty tests. Your format, you should always be using an APA title page. You have clear headers and your formatting that we are able to see. You're using good grammar, you have you have appropriate spelling and correct medical terminology, and that your content is complete with a summary of all of those objective findings. You want to be very specific in mentioning each area that you covered in detail of your exam. That is MSK and integumentary in a nutshell. And this is week 7. So this is your last sync session that you will have for MSN572. In week 8, you will be completing your final assignments, which are your group 8 week assignment, that diagnostic. And so you will follow your announcements from your instructor at that point. I wish you the best and the most success in performing your head to toe. Remember, if you need a review of that, that's in your week 5 video. Thank you so much.